Okay, so hello everyone, and thank you for being here today. Today I would like to talk or to speak about designing gender-sensitive recruitment for health research. The main argument I want to make is that recruitment is not just a practical step before the real research starts. It produces the evidence that we are going to see. So the recruitment will have an effect on which evidence we will produce. Thank you so much.
Sorry.
The main argument I want to make is that recruitment is not just a practical step before the real research starts. But recruitment produces, or it's going to produce the evidence that we're going to see. It's going to show us which symptoms, which experiences of people are going to be seen in innovations, in guidelines, and so on. So today I want to invite you to look at recruitment not just as a practical step, just more as a methodological, ethical, and social step. Before to start, I want to briefly introduce myself and my research. So my name is Abdel. I am a PhD student at Radboudumc in Nijmegen. And I do research on the gender dimensions of health-related quality of life and rheumatic diseases. To be more specific, I'm using quantitative, qualitative, and design-based methods. So questionnaires, interviews, and also designing together with patients, physicians, nurses, and so on, to make guidelines to create more gender-sensitive guidelines for rheumatology care. And I'm also focused on gender-sensitive and inclusive research methods and involved at several early career networks for sensitive gender. And my interest in recruitment does not come from theory alone. It comes also from problems that we had in my own research, where I saw that implementation cannot be assumed. It needs to be designed. So my talk today is structured around these 5 parts. First, I want to explain why recruitment matters. So why it should be seen as a third decision step in the research. Then I want to explain what we did in my own research. So in my own questionnaire study, what did we do to include those participants? Then I want to briefly introduce or explain how to personalize sex and gender in questionnaire studies, because the question that you ask will also have an effect on the inclusion. After that, I want to give some practical framework on how to perform gender-specific recruitment. And finally, I want to end with some examples from my own research, so the problems that we had and how we try to solve. So this slide shows one of the main ideas of my talk. So recruitment is where medicine, technology, sociology, and intersectional design come together. From a medical perspective, the recruitment shapes who becomes visible in so in guidelines, innovations, and so on. In technology, from a technological perspective, digital pathways can widen the access, they can also produce bias. From a sociological perspective, trust, language, norms, and so on can shape the career of people feel safe enough to participate in research. And from an intersectional design perspective, it's important to know that people are not just a patient or a woman, or there are different identities that come together and shape the person. So when I'm talking about recruitment, I'm not just talking about having enough participants to move on with research, but I'm talking about a place where different systems come together. And this leads me to the problem. Recruitment is going to shape or is shaping the evidence that we produce. So if you talk about recruitment, as I told you before, it's going to shape the information that we have, the evidence that we are going to produce, and the innovations, and also the guidelines that we're going to have at the end. And if we talk about research quality, we often look at, for example, the analysis, we look at the instruments, we look at the interpretation of the results. Before all of that, it's an important question that we need to ask. Who's going to be able to enter the research, so enter your experience, for example? And at every step of your research, there are going to be some people that are going to be leaving or be excluded. For example, people are not going to see the invitation. Some people see the invitation but don't understand it. Some people understand the invitation but don't trust it. Some people trust it but can still not participate because, for example, there's a high burden for your research. So it's important to know that exclusion does not happen once you start with the analysis. It happens much earlier. And once that you know that exclusion is going to be happening earlier, and that you know that inclusion is not going to be assumed, but that you need to decide for it, you can act on it. This slide shows a few examples of why people are getting left out. For example, some people face language barriers. For example, the invitation is written too academically, so people cannot really understand it. Other people have low health literacy. So, for example, they get a lot of information before even they start within your study. And some people face also digital exclusion. For example, they don't have access to digital pathways. Others face, for example, stigma, mistrust, or being feared of being exposed. For example, people that are closeted in LGBTQ communities are feeling, let's say, feared to participate in certain studies because they think, oh, maybe I'm going to be exposed to the community or to people thinking like, okay, they know about it. Some people have caregiving burden, for example, childcare. How are you going to go to a hospital to do a certain experiment if you don't have time or you need to care for the children? And some people, especially in rheumatology, can have pain, fatigue, or mobility issues. Especially within rheumatology, that's where I specialize in. We see that patients don't have a lot of energy. Sometimes they really have just a few hours a day, but they can have enough energy to participate in research or do their tasks. So we need to account for this. And also, when we talk about underrepresented population, we often talk about women. That's also the main topic of today. But we also need to think about men, for example, in questionnaire studies. Research has shown that men often are underrepresented in questionnaire studies, especially gender diverse people. So what I want to show is that the term hard to reach is like misleading. It tells more about your own research and your own design than about the population that you want to reach. And here again, I want to reduce different barriers into 4 categories. We have the structural category. It's about historic exclusion. Think about pregnant women. We have the relational category. It's about mistrust, stigma, people thinking this research is not for people like me, so they don't feel really identified with. And then the most important, communicative barriers. Think about the invitations related to academically written, or you use the wrong imagery or examples. For example, within rheumatology, again, if you look at rheumatology, just in Europe, we're going to often see women, older women, or hands. For example, hands with a red dot or something like that. So people that have different symptoms, for example, they have pain in other joints or something like that, they're not going to feel identified with your pictures that you use or the words that you use. So you should also think about this kind of things. And practical is more about, again, the fatigue, complex, for example, too many follow-ups, and people cannot participate because of that. So different barriers that also lead to different intervention. If you only design one flyer and want to include the entire population, that's not going to be possible. And this is one of the main, or I think one of the most important parts I really hope stays with you. Underrepresentation is produced, it's not random. When people are missing from research, we often ask, why are they not participating? Instead of thinking, what did we do wrong so that they are not present in our sample? So that's one of the most important parts to think about. When the representation is produced, it's not random. You should ask questions like, did they get the invitation? Did they understand the invitation? What's happening? Why are they not present? What did we do wrong? Instead of why are they not present? So not giving the fault to the community, but thinking out how can we reach them. And also exclusion is often structural. So it's often seen as something structural before in numbers. This is an example to show that wording really matters. This is an slide that we use for the recruitment of participants for my questionnaire study. It's in Dutch, but I'm going to try to explain it. So we often, in the beginning, we use the left one, where you see research on the role of gender in rheumatic diseases. Then we ask patient representatives, what do you think about this flyer? Do you understand what we are asking for you? Do you understand who should be involved in the research? And when they read the word gender, they often thought it was about transgender people. And it was not with one patient representative, with multiple. So we then decided to just change one word from gender to male, female differences, and then we can do it for everyone. So also the words that you are choosing can really have a huge impact. And again, not only the words, but also the picture that you are choosing. Also, there's like a big or strong temptation in research to use easy or simple recruitment pathways to have, or being happy that you see like a lot of people are coming in. It can also have price. For example, these pathways often reach the same people, which will result in biased estimates. For example, within your own data, you're going to have very clean results, or for example, more stable results than in reality, because you are sampling a certain population the entire time from the same path. Another example, or what it can lead to big implementations, because your interventions or implementations are based on a small part of the entire population and not the entire population. And also this will reproduce the inequalities. So the groups that are already underrepresented will stay underrepresented because you are using the easiest recruitment pathways. And this will also lead to lower trust because communities really know when research is happening around them instead with them. So also if you see easy to recruit, it's often the opposite of good enough to generalize. Because if you can recruit very easily and you see that your sample size is filled, your sample is filled very quickly, you should then ask even more questions. Okay, did we have or did we recruit everyone to include everyone that we needed or not? And now I want to tell you what I did for my own research. So my research was about the impact of gender dimensions for rheumatic diseases. We performed a questionnaire study. In this questionnaire study, we wanted to see which gender dimensions have the biggest impact on the health-related quality of life. And to do so, we needed approximately 500 participants. And we tried different recruitment strategies. First of all, or one of the most used is social media. Think about Facebook groups, Instagram, TikTok, LinkedIn, and so on. We also use hospital schools, not only from the university hospitals, but also from like smaller hospitals that have big rheumatology departments. We also use, and very important, patient associations, not only the national patient associations like the Dutch Society for Rheumatology, but also the smaller patient associations. For example, the one in Nijmegen, not one in Amsterdam, or in Rotterdam. So you only have like national coverage, but also from local places. And also one of the most used recruiting pathways are clinicians. We also ask them to help us recruit patients, and we use patients, often hospitals or departments like the rheumatology department, have patients list, and you can just send them an invitation and ask, hey, do you want to participate in this research? And we also use newsletters, for example, newsletters of hospitals or patient association. What I want you to remember from this is that no single route is going to reach everyone. For different people, we're going to need different recruitment strategies. For example, social media is going to be very easy to use. We can reach a lot of people, have a very wide geographical reach, but maybe you're going to miss some. For the hospital experience, it's a place where people really trust. For example, visiting care settings. So in hospitals, often when patients come to their care, they trust their caregivers, so they also want to trust the research that's happening there. Patient associations or patient groups are very important because they can give you community trust. Often you have like very motivated participants with deep patient associations, and they're going to share your information with other patients, for example. Clinicians are giving legitimacy, for example, because if you just post your research on social media, in Facebook, people are going to be like, okay, I don't trust it. But once clinicians or patient associations also talk about it, the legitimacy is going to increase. And newsletters can be used as a secondary amplification. And the question that you need to ask yourself is not which channel is the best to recruit participants, but how can you balance between the different channels. For example, if you use social media, the chances are high that you miss people of a certain age. But you can do that, for example, use clinicians to target those patients. So think about which recruiting strategies are going to balance each other instead of thinking, okay, which one is the best one or which one is the easiest, because then you get again in the presentation. Let's say with social media. Social media has a lot of things that they can do, but also a lot of things they cannot. Again, it's very easy. Normally, it's often free or very cheap to perform recruitment. You can reach a lot of people at the same time. But there are also some limitations for using just social media for recruitment. Older participants are going to be missed. People outside of this digital ecosystem are going to be missed, and you can also produce some bias. So if your recruitment is only digital, you already have like a biased or selective sample. That's why clinicians and patient organizations are so important. They can be used as trust multipliers. So you can start, for example, with social media and so on, but you can also ask clinicians, because they are often seen as trusted messengers. They can help you to reach the participants that you don't reach with social media. But also patient organizations, you need to think about, for example, the participants that clinicians can also have like a negative impact. They can, for example, select participants based on their experience. So you need to think about that. And also patient organizations, again, they're very important to be included at several steps of your research. They can create community trust. People, if they see it on the website, they're more eager to participate in the research instead of just seeing it on Facebook, for example. And again, it's about the balance. There is not a single best recruitment strategy. It's about trying to use different recruitment strategies and to see what's the balance. And now I want to briefly explain how to personalize sex and gender research, more specifically in questionnaire or survey research, because the questions that you ask also have an impact on the inclusion. So first of all, focus already in the first session of the cycles of care, very briefly why it's important to consider sex and gender in the research. We know that diseases do not affect everyone in the same way. For example, especially in cardiovascular diseases, there are those differences in symptom presentation. Think about the typical male symptoms of having chest pain with females tend, for example, vomiting of pain in the neck or something like that. But also the differences in disease risk, diagnosis, treatment, and so on. Historically, research has mostly focused on sex differences, let's say only on sex differences. And in the last few years, there's more and more recent recognition that gender also has an impact on the health and quality of life. So integrating sex and gender will improve your scientific quality and relevance. What's the difference between sex and gender? Very shortly, sex is about the three G's. So genetics, the hormones, and genitalia. And it's often operationalized as sex assigned at birth. And sadly enough, it's often reduced to this binary category of variables, female and male, but we also need to think about intersex people. It's a very small part of the population, but still big enough. It's 1% of the entire population approximately. And if you talk about gender is a social cultural construct. It exists on different dimensions. We have gender identity, so do you identify as a man, woman, non-binary, something else? Gender expression, how do you show yourself to the world? For example, through clothing. Gender roles and norms, what does the society expect from men and women? And gender relations, how are research divided between different gender identities? So sex and gender are related to each other, but are not the same. And it's also a very important thing that I hope that you remember, they're not the same, and you should look at them differently. But how do you ask for sex and gender? This is a very important part. If we often use the two-step method, we first ask for sex assigned at birth. So you really try to explain what is sex assigned at birth, and then you explain what's gender identity. So you ask for sex assigned at birth, you pick the options male, female, intersex. And then also another option, I prefer not to answer that, I'm going to go deeper into that in a second. And for gender identity, you ask for superb gender identity. So it's woman, man, non-binary, not identity, prefer not to answer. I'm not sure how it is in German and French. For Dutch, for example, there's not a difference between male, man, female, woman. I'm not sure it's in that. It's not it's the same as in our part. What we then try to do is to use the information dots to explain the differences, because in Dutch it really looks like that: man, vrouw, and vrouw. So you don't see the difference in the wording. So you try to explain. You ask what is your sex assigned at birth, and then you really explain. Okay, when you were born, which sex did they give you? Male, female. It's often one of both. It's almost never going to be someone telling you it's going to be intersex, or happens later. And then you try to explain what's the gender identity and what's the difference between sex and gender identity. And then ask again, what's your current gender identity? And not only that, it's important for us for inclusion. You need to explain what you're asking. If you just give, for example, what is your sex assigned at birth, what's your gender identity, people are not going to understand it, or are going to have the feeling that's maybe too personal. And that's why the option is another option. We prefer not to answer. We should always give them. Because some people think, especially maybe 2%, who want to answer it, and then you're going to list them from the entire questionnaire, from the entire research, just because they didn't want to answer, for example, the part of what's your gender identity. And not move on. So to have a more practical framework on how to design, or I'm going to try to explain how to design more gender-sensitive recruitment. First of all, you need to start with an inclusion hypothesis. So there are a few questions that you need to ask yourself, your team, before you start with the recruitment. Which students are most likely to be missing if we don't do anything differently from what's written in the protocol? What barriers do they face before consent? For example, think about the boarding, think about trust, think about relevance, logistics. Can they come to the hospital to do a certain test? Or do they need to work? Can they also come after working hours? Think about the messenger. Which messenger do they trust? Can you just put it online? Or is really a clinician needed to ask the participants to participate in the research? That would make participation feel possible, not just theoretical. For example, you can say, yeah, we try to recruit everyone. If you don't really make it with very clear examples possible, then it's going to be difficult to include everyone. Think again about people that are working. Can they also participate in your research after working hours or in the weekend, for example? These simple examples. And also, what research are we willing to allocate to reach them? This is an important part. Because recruitment or inclusive recruitment should not be just like a nice sentence in the protocol. It needs time, money, and people working on it. And the second part, and that's also the second most important part of my talk, nothing about us without us. So it's important to cooperate together with the community instead of just deciding everything by yourself with your team and doing research. First of all, listen. So what will make this invitation land better? Think about your invitation for your research. And you can go to a patient representative of people with lived experience and ask them what you think about this. Think about the word gender, male, female differences. And also what feels expected. That means, do the participants have the feeling that the scientists just come to them to collect the data and they go without giving anything back? Or you can also just, with the small part, telling the participants, hey, you want to participate in my research, and at the end you're going to get results. Then you will see that the percentage of people that really want to participate is going to increase. People really want, if they did a small part, just seeing the results of the paper at the end is going to help them. Also, so this rewarding, think about gender, male, female differences. Think about the visuals that you use. You only use females, only use males, because that will also have an impact on the people. They recognize themselves with the flyers, for example. And also, who's still missing? So once you start with your recruitment, you monitor and think, okay, we're still missing. How can we change things and compensate? Recruitment is often like a very small part of the protocol or of your entire planning. And people don't really think that recruitment also needs money, for example. If you want to ask patient representatives, do you want to take my flyers? And they need to come to your hospital, for example. You need to have, it's not a lot. For example, 10 euros to pay the transport costs, these kind of things. But think about that at the beginning instead of afterwards. And also, do not design for people when you can design with. And this brings me to the involvement matrix. So this matrix shows that the patient representatives of people with lived experience can be involved in your research at different levels, at different times. And we hope that most of the researchers use the co-thinker part at least. In this part, you're going to ask the patient representative to give feedback on your materials. Think about your information letters, think about your flyers, think about your questionnaires. For example, in my case, in the question, we often just use the word gender because you create that question with your teammates and everyone knows gender is depending on sex differences. The people outside of your bubble sometimes don't understand certain words. So ask them. Also, they can tell you more about certain barriers that people face. For example, the part of the energy, I didn't realize at the beginning, patients with rheumatic diseases don't have a lot of energy. My question was 30 minutes. So you can imagine if someone has only 5 hours a day or 4 hours a day to have energy to do things, they will have to waste 30 minutes filling your questions. So also think about this kind of things. And they can comment on lessons. For example, at the end of my research, I want to give recommendations for how to create more gender-sensitive rheumatology care. So they can also give their insights on that. Or if you want to go a few steps further, for example, you can go with a partner. Then you can really co-design with your patient representative. Then they're involved from the beginning, for example. They're going to co-design your research. They're going to help you to recruit participants. And they will also co-present your findings. So not just that you are the one presenting the information of the results, they will help you to spread that information with the author associations, for example. And if I need to bring all those recommendations together in 6 steps, this will be the 6 steps that I think are the best performing gender-sensitive recruitment. First of all, diagnose. So map who is missing or who is going to be missing and why. Think about everything that you can come up with, and also with patient representative. Ask them what do they think is going to be like a barrier for your research. Then partner, so the partner can partner work with communities together instead of just doing everything by your own. Really ask them for their help, for their insights. Step 3 is adapt. So be flexible. Be able to change your language, formats, timing, burden. For example, the 30-minute questionnaire could also be divided in smaller parts and be filled in sometimes instead of in one time. Another part is diversify. So use a mixed channel strategy. Not only one recruitment strategy, but think again about the balance. So if I'm using a certain recruitment strategy, who is missing using only that recruitment strategy? And how can I balance to find those people that are missing this strategy? Support, again, it's a little bit budget, not a lot. Think about that at the beginning. And report. I think that's the most important part. So track and share subgroup results. At this moment, if you look at journals, it's not really a mandatory part to also report about the subgroups that you have. Often you only give the total sample size at the end, and that's it. It's telling also about who's involved, who's not, or what worked with for your recruitment, but what not, who's missing even at the end. That can help to shape future research. And this is a very practical recommendation. Again, it's about monitoring. So in real time, break it down into sex assigned birth and gender identity. So while you are recruiting participants, think about or try to analyze, okay, do we have more males or more females? Who are we missing? Try to look at also age. There are just often very small questions that you ask at the beginning of the questionnaire or whatever research you do. Often ask for sex assigned birth, often ask for gender identity, you ask for age, and you can also ask how did you find us or how did you get into this research? And also the reason for dropout. It really depends on the research question that you have. If you are, for example, testing a vaccine, then you really need to ask why are you dropping out. They can also choose to not give any reason and just drop out. Often they're going to tell you, for example, I have too many side effects or it's too many follow-ups or something like that. But if you are doing a questionnaire, it's difficult to ask people, why did you not fill in the entire questionnaire? Send the questionnaire, and you wait until it's filled in, and they give it back. But what you can do, for example, is try, while you are recruiting, while people are filling the questionnaires, try to see what's the difference between the people that fill the questionnaire fully and the people that stop, for example, in the half, like in the half of the questionnaire. And see, is this really random? Or do all those people have certain characteristics that are the same? For example, are all those people from a certain age? Are all these people, for example, male? Are they all female? And how you can adapt to it? Because if you only measure the final sample, you miss why and when exclusion is happening, then you can also not adapt to it. So if you measure it while you are recruiting, you can also adapt your recruiting strategy and be sure that you have enough people and diversify education. Now I want to give you a few examples from my own research that happened and what we tried to do to solve these problems. First of all, we used like a multi-channel strategy. So we used a lot of different recruitment strategies to try and have a very wide population, for example, also not only using one hospital, but all the hospitals in the Netherlands to have a broad geographical distribution. And also not only using the national society, but also the smaller societies. And still at the end, there are a limited amount of men in our group. Younger adults were also missing, and people outside the existing patient networks were also easier to miss. And also something that's very important, interest does not always translate into participation. For example, in my case, 952 participants told us that they want to fill in the questionnaire. So we sent the questionnaire to 952 participants, but at the end, only around 500-600 people filled in the entire questionnaire. So it's important to know that it's not because people are interested, but they're really going to fill in the entire question. And being open to everyone does not mean everyone's really reachable. So what did we try to do? For example, for male participants or for men, we tried to ask clinicians to really target them. So we had enough women in our sample. We asked clinicians, hey, can you please recruit or try to recruit more men than women? Keep more attention to that. Also, the wording and examples that we use, instead of just using female pictures of from heads, also giving examples of males. And for young adults, if you look at the National Rheumatology Association, for example, if you look at the members, you will see that 95 or even 99% of the members are of a certain age, like the whole population. So we thought, okay, maybe there's another group, and started looking around, and we found another more youth-oriented organization for rheumatology patients. And we tried to contact them and to ask, hey, can you help us with the recruitment? And also think about more channels closer to their daily life, Facebook, Instagram, TikTok, and so on. And also, if we need to know if the problems or the barriers are layered, the solutions will also be layered to try to still have everyone included. So more strategies do not ultimately remove all barriers, because even using different recruitment strategies, different offers to try to recruit everyone, there's still going to be a few people missing. For example, in our part, as of important to understand, hard to reach doesn't always mean that those people are hard to reach. Maybe our invitation didn't reach them at all. Also, some people don't see this as relevant to them. You also need to think about your own research question, your own research. For example, in my case, it's the impact of gender dimensions on rheumatic disease. For a lot of people, this is going to be too woke or not important. They think that's some woke parts, some left parts, so they don't think it's important enough to fill in the questionnaire, for example. Some barriers about trust, time, fatigue, stigma, or identity. Again, for example, the fatigue part, I didn't know that people really have this big amount of energy. So talking to our patient representatives again helped us to understand, okay, what's going wrong? How can we adapt that really result in more participants? Because now that we fill in the question multiple times, we set in just one time. And also clinicians and patient organizations can help. They cannot solve everything. And also they can also result in more bias, let's say, of more selection again, because you are selecting more participants that are more in the hospitals. And the most important part, recruitment, is monitoring, adaptation, and honestly reporting. So monitor who is recruited, who is not. How can we adapt to have the type of population presented? And just report it honestly in your papers. Don't give the total sample size, but give also per group, for example. And if I should summarize recruitment into three important key principles, let's say, the first one and the most important one is the language part. So if people do not understand your invitation, they are not fully invited from the beginning. If you have a flyer that people don't understand, and they are not really invited. So again, work again with patient representatives to see if they get it or not. The second one is trust. People do not join systems because we ask them to join our questionnaire or our study. They join systems because they feel safe, heard, respected. And you can just give a small part back. For example, ask them to give the following questionnaire, and then you want to share with them the results, for example. And relevance. As it may be open, but it still feels the invitation ignores the real life work. Think of healthcare, taking care of children, for example. Are we going to provide someone that's going to take care of the children while the patient participants taking, for example, some blood? Are we going to divide the questionnaire in multiple parts? Are we going to be able to, again, for example, let's say collect blood in the weekends after working hours? Also, these real life barriers should take into account before we start recruitment. That's important. So, inclusive recruitment is not only about reach, but about understanding, trust, and purpose. And now I want to zoom a little bit out and tell you more about the responsibilities. Often recruitment is seen as a responsibility for the researcher or the research group. It's a shared responsibility. And this brings us to a broader reflection. In the beginning or previously, recruitment was seen as, let's start to recruit participants. Once we have enough members or enough participants, we close our questionnaire or our research experiment, let's say. We start with the analysis, and underrepresentation was seen as normal. Saying like, okay, yeah, women are underrepresented, was seen as normal thing. Or saying that, for example, members of the LGBT community are underrepresented, it was all seen as normal. But now there is more like a shift in those thinking or in these ideas. We really try, or really hope that everyone tries to build more relationships with the community. So really going to the patient organization, going to participants of your own research, and ask them for help, ask them to be involved in your research. They can help to shape your questionnaires, your flyers, your invitation letters, and so on. And also there is more and more attention to give also some funding for the recruitment path. Better recruitment will also lead to better science and yeah. And inclusion is not charity. So like let's say right inclusion is not just about charity, it's really something that it's not about just a part that we do next to the real research, it's about justice. If we have a certain research and let's say a part of the population is missing every time, then we keep creating the same evidence and we keep missing those people. So we need to think about whose pain is important. Is everyone's pain important or just a small part of the population that we're targeting? Whose lives should be innovations? Because again, the evidence that you create is influenced by the recruitment that you make, and it will also then influence the guidelines with the innovation that you create. Those innovations or those guidelines are going to be limited for the population that was in the research, for example. And also, who remains invisible? Think about that even at the end, even if you use several recruitment strategies, there are going to be people that are still missing. That can help to shape future research. We can say at the end, like, hey, we try to recruit, we tried everything we could. These parts of the population are still missing in our research. Then a future researcher can, for example, try to go into that. So inclusive recruitment is an early justice decision. Now, the inclusion is not about recruitment only. We have recruitment, so that's about who is getting in our research. We have participation. That means who has a voice. So can they, for example, help you to shape your materials, think about the flyers and so on. So inclusion is more about also having a voice in the research, not just filling a questionnaire and that's it. And I want to end with this slide. So the responsibility is not only for the researchers, but it's a joint responsibility with us, founders, funders, ethics boards, journals, and care organizations. For funders, for example, they should not only give attention or give, let's say, priority to collecting data, but also give priority to creating a communication or creating a relationship with the communities. From an ethics board, they should give guidance on how to create communication with the community, for example, relations with the communities. Journals should require, this is an important part, require reporting of subgroups, because now you often just require the total sample size. What are the most researchers going to do? Also only give the total sample size. So also requiring something is going to be very important for people. And care organizations, really working together with the communities, with the patient representatives, with people with lived experience, will really bring your research to another level. It's going to be more about with them instead of just about them. And if inclusion is not funded, enabled, and required, it's not going to happen, because often people, as long as it's not required, they're not going to do that. They'll think yeah, it's a nice add-on, but this should be something that's not added to your research, it should be the basic research. So the main or take-home messages that I have for you: recruitment is not just a logistical step; it's more about ethics, social, political, even. Underrepresentation is produced; it's not random. It's really depending on the decisions that you made during your recruitment. Mixed channel recruitment works best when it's anchored into trust, flexibility, and shared power. And again, think about the balance. Who do we get with a certain recruitment strategy? Who do we miss? And which recruitment strategy can we use to get those people into your research? And also, nothing about us without us. That's the most important part. So work together with the community, so instead of working for them without them. And if you want inclusive digital women's health, you must build evidence with people, not only about them. So thank you very much for listening. If there are any questions, please ask. I also added 2 QR codes. One is if you are interested in sex and gender health research, and join the roundtable in the newsletters. Thank you very much.
After this amazing talk, we have prepared a little thank you for your work. So thanks a lot for doing. And I'm pretty sure some of you have a question. I run around with the microphone. Did you have some?
Thank you so much for the lovely talk. It was really super interesting. I have a questions about the patient representatives that you included in your studies, because I do as well, but whenever I ask them, I feel like I'm adding yet another burden to what they're already doing for the community. And I'm like, I mean, of course I can communicate my results back, but what has been your experience with this kind of additional factor while including the community in your recruitment or in your work?
It really depends on your research question and your community, let's say. In my case, for example, they were very enthusiastic to participate because they saw a lot of research happens about them without them. So it's not often that researchers go to participate to the representative and ask like, hey, what do you think about this? What do you think about the question? Do we miss any questions? So not only about the work, but about what to really try to research. And they also have us to ask some questions to, and also giving the information back, like explaining like, hey, once I have the results, I'm going to show them to you. Or for example, invite them to your PhD defense. It's also something that they really like having, as long as you give them the feeling that they do something that they can contribute to your research instead of just giving in or answering the questions. That's really going to help them, or giving them the feeling that they can contribute to research. And then they are more eager to help, I think.
Another question? Christoph? Yes.
You've mentioned at some point that you adjusted the wording, for example, to address men better in a specific case. Can you give an example how you did that? Or
it was
Like what you changed in the
yeah, that was a difficult part. It was more about pictures that we used, for example, instead of giving like, okay, for example, you ask also participants which stereotypes there are around rheumatology. And often people think about an old woman. So we try to, if you look on Google, you just write rheumatology or rheumatic disease, you often see hands, for example, like a red dot, and people that have problems somewhere else are not really identified with that. Or even the pictures of those hands are sometimes mostly like from women. So trying to use the right pictures to show like, hey, it's not only about them, but about everyone. Then they feel more like connected with them, with the picture that they see and the wording that they see, and then they try to include more. The wording part was indeed difficult.
Thank you. Actually, I had that question with the wording part.
Yeah.
More wording about the sex and gender differences, because I mean, I have an app where for women's health, but there are even simple things like saying, is your symptom mild, moderate, or severe? Like, what does that mean? So now I'm wondering if you ask them sex and gender and say, mark your sex and mark your gender, how did you explain, how did you go around it, explaining to them your
the sex and gender part?
Yeah, differences between, like, you know, if they have to mark their sex and then they have to mark their gender separately. How did you go about explaining that this is what we mean and this is what we mean?
This was very difficult, and we tried multiple times. And to be honest, that's the question that we have within our own unit that we discussed multiple parts of how do we pass sex and gender, how do we explain that to people. And the way that I try to do it right now, it's not really clear, it's also best. So what I try to do, for example, when we ask about sex, we really say when you were born, where you were, for example. So trying to explain it in that way so people really get it. And about talk about gender identity, we say like, hey, maybe your gender identity at the moment is not the same as what you were assigned at birth. And then they kind of get it. But to be honest, if you look at the 600 plus people that's filling my question in things like no single person that's like transgender, for example, non-binary, often you will still have like male, female, or man, woman.
And you did this for this rheumatoid arthritis population also?
Yeah. But again, we try to really explain, just give as much information as we can, as easy as possible. Sometimes we give examples that don't really look the best. As saying, for example, when you were born, before you grow up, that's a bit, stigma something like that. It's so that helps for them to understand what's the difference between those. Also, introducing your questions every time. For example, in the gender identity, before we ask them the question sex identity for gender identity, we already introduced it. So say the next questions are going to be about the gender dimensions, more specifically about gender identity. Some people can feel it more personal, so you're going to answer these questions as well and try to explain what is the difference. And again, with the information dot, explaining again. So people read because if they don't press on the information dot, for example, they see the same question twice and they don't get it. So that's why you need to introduce your questions before asking them. That's how to do it.
I have a
follow-up question.
Yeah.
Since I'm working with children from the age of 8 to 17, I also ask them about their gender, and they are so confused.
Yeah.
And I'm asking them, I try to like adjust a little bit, that I kind of introduce the concept that some people do not feel the same as they were born, but still they're very confused. So now I'm thinking about if I should ask beforehand the parents to not ask it, but I'm not quite sure if it's the right way. What are your thoughts about children 8 to 17?
It really depends. For example, a 16-year-old and an 8-year-old, they currently have totally different responses, let's say. And I don't think that you really need to include the parents in such parts. For example, especially in these, let's say, more vulnerable questions. If there's a boy that already identifies himself as a girl, and you ask the parents, they're going to be like, no, it's a boy again. So try to explain to the children and not include the parents when you ask this kind of question. For example, also in interviews, when we ask this kind of questions, we ask, can you go in the room? No. So they have the feeling, okay, they can talk freely and it's all anonymized, so they feel still free to talk. Once you try to include the parents, again, it really depends on the research question, the setting, and everything. If you include them, then people are more hesitant to give their real answers. and maybe try to ask children how do they understand your explanation that you give them, and how do they think that's going to explain that. That's my estimate.
Yeah, that's also what I thought, but if somebody has other ideas, so we can also
talk about it later. That would be wonderful. Any other questions?
Sorry, this is one more question. So now when you're talking about women's health, now one thing we were thinking of, we should say menstruators, because again you have the whole gender fluidity and where people are so. How would you? I mean, how do you talk about it, or like in your whole the whole picture of your survey, because it's for women, for women in terms of sex, but it's for the gender fluid people.
Like, let's say about part of menstruation. I think several research groups ask that in different ways. Some people really say menstruating people. A lot of people get that. So again, it really depends on your research question and your target population. If you want to ask about postmenopause people of a certain age, then you need to really ask, do you get the word menstruating people? Or do you really want to use the word female or woman? Because then it's the chance higher that people understand what you want to research. So it really depends on your research question, your research target population, your setting, and you can always ask them, do they get that? And I think if you look online for the same question, you're going to find multiple answers, because there are multiple places, and I hear multiple. And personally, I think menstruating people is the easiest or the most inclusive. If someone tries like this, please.
In research where you're like in menstrual health research, yes, I would say it's close. I think like in my research group, we almost always start discussing this question for each paper again. With each new master student, we start discussing it again, because sometimes we want to do a menstrual health research and also ask people who are currently not menstruating. Or who are not menstruating anymore because they not have their uterus, like these kind of things. It's super hard, and I think we often try to mention as many words as possible terms to catch a lot of people. But it's super hard.
Yeah. I think also
it's not perfect.
Yeah. But I think the best thing to do will be like find one common sentence that everyone uses, because if you look at flyers, often you see the same question multiple times in multiple different ways. So if there are like consensus on how to ask that, to use the most used question, will help you.
So when would you say that the research population is inclusive enough, or that you've done your job well and there's no further optimizations?
That's a very good question. Thank you for that. I don't think there's like a universal threshold and say, okay, that's what you want, it's inclusive enough. Let's say that. It really again depends on your research question and your target population. Your target population, in my case, is people that have extra PESAs, sclerosis, and SLA. And I'm going to try or really hope to have like a wide population representation of the real population. For example, if I see that 80% of the people are female, 20% of the people with stem cells are male, then I know, okay, if my questionnaire is 80-20, it's fine. Then I really try to look, okay, at the age. So try to look at the real world evidence and to kind of limit that. That's very difficult. It's really, as long as you really try different pathways to include as many people as possible, I think that's fine. I don't think there's like a universal threshold, like, okay, if you have so many people of this age, of this background, of this cultural background, of this nationality, of this age, I don't think there's like this threshold.
So the idea is you want to have your study population mirror the actual population as closely as possible?
That can be risky because sometimes the evidence of this, for example, for psoriatic arthritis, in the beginning it was thought as it's male disease, and now evidence shows it's 50-50. So try to limit it, but not only look at that. Really try to have as a wide recruitment strategy to include as many people as possible. It's difficult to say or when it's inclusive enough. I think as long as we try to best to recruit from different pathways, from the hospital, also outside of hospitals, from different ages, from different backgrounds, aiming for a whole that will break those down.
Yeah, and I'm just asking because we're looking, for example, at prevention. How do you know that your population is then inclusive enough, right? So, I don't know if it's a question for you to want it to then mirror the actual population, but you know that some people are more vulnerable and more likely to develop the disease, right? So, yeah, it's an interesting question.
To be honest, it's a question that I was struggling with several of my colleagues, and we're thinking, okay, when do you have enough people? When do you have enough? For example, if I perform statistical analysis, I only needed 255, something like that. But then if I look at the population, it was like 90% people. Then I know, okay, something is going wrong. Now, because at the age of like immigration background, I mean, okay, it's not what we see in the hospital, what we see in the street, what we ask participants that we see. So then try to maybe not only what's evidence in science, also what people really know about the, for example, psoriatic arthritis, we know there's 50-50%. So try to include enough males as females, and not only having like 90% female, 10% male. It's a very difficult question to answer. There's not like the universal rule. I think as long as we try to define people, that's the best we can.
Good. So we can. Is it okay? Yeah.